breast cancer, the most important treatment decision we make is often the very first one. Okay, so I'm Dr. Kylie Loh from Penang Adventist Hospital in Malaysia. It's my pleasure to chair this AZ Symposium on evidence to action in first-line HER2, early and metastatic decisions. So this session focuses on first-line decision-making because the choices we make at the beginning will shape outcomes, CNS control, tolerability, and the options that are available later on. And importantly, it's about how we translate data into real-world practice, especially across our diverse Asian settings. So I am delighted to introduce our faculty. So firstly is Professor Lee Soo Chin from NCIS, who needs no further introduction, who will discuss the advances in first-line HER2-positive early breast cancer from neoadjuvant to adjuvant therapy. And secondly, it will be Professor Shahina Dawood, who also needs no further introduction, who will take us through month 0, decision-making in HER2-positive metastatic breast cancer. And later, joining us for the case-based discussion would be Professor Lu Yan Chen from National Taiwan University Hospital. So with that, let's get straight into the science. It's my pleasure to invite Professor Lee Soo Chin.
Thank you, Kylie, for the kind introduction. So it's great everybody got their lunch. Okay, so I'm going to talk about advances in management of HER2-positive early breast cancer. Okay, so that's my slides. Okay, these are my disclosures again. Okay, so in the current management algorithm in HER2-positive early breast cancer, the first major decision that we are making for any newly diagnosed HER2-positive early breast cancer is to decide, is this patient going for upfront surgery, or are we going to be giving neoadjuvant systemic therapy? And if the plan is to go for upfront surgery, we will risk stratify these patients based on their final pathological stage and then recommend adjuvant therapy based on those risks. For a patient who undergo neoadjuvant systemic therapy, our first primary objective is to achieve PCR. And then post-surgery, the adjuvant therapy will be determined by the PCR status, and a non-PCR patient will receive escalated adjuvant therapy, and our current standard is TDM1. But there is a general trend to move more towards neoadjuvant therapy because there is more scope to improve outcome in this setting. And indeed, in the neoadjuvant approach, there are several opportunities for drug development. So on the one hand, we can try to develop more effective neoadjuvant systemic therapies to increase PCR rate. And then on the other hand, we can also develop more effective escalated adjuvant therapy options for the non-PCR patients to improve survival. So let's start with developing more effective neoadjuvant therapy regimens in HER2-positive early breast cancer. And if you look at the historical progression in neoadjuvant systemic therapy in this setting, before the availability of HER2 blockade, if we were to give just combination anthracyclines taxanes to these patients, we can only achieve PCR in 15 to 20% of patients. And subsequent trials showed that adding just single-agent trastuzumab to the same anthracyclines taxanes backbone can double this PCR to about 35 to 40%. And then the NeoSphere trial showed that giving a dual HER2 blockade, but with just single-agent taxanes, can achieve PCR in 46%. Then we have a series of other trials subsequently, including the Trifina, the Gepercepto, as well as the Christine trial, showing that dual HER2 blockade with combination chemotherapy, this could be anthracyclines or non-anthracyclines containing, could push the PCR rates to more than 50 to 60%. And then there is the phase 3 randomized TRAIN2 trial that directly compared dual HER2 blockade plus combination anthracyclines chemo or non-anthracyclines chemo and showed that they are the same. So based on these series of trials, dual HER2 blockade plus combination chemotherapy, be it anthracyclines or non-anthracyclines, is our current standard. But if you look at these results, you appreciate that a good 30 to 40% of patients will still do not achieve PCR with the current best standard, highlighting that there is indeed scope to develop more effective regimens. So the Destiny Breast 11 trial is exactly one such trial to develop more effective neoadjuvant therapy regimen in the higher risk HER2-positive early breast cancer patients. This is a phase 3 randomized trial that enrolled over 900 patients with high-risk clinical stage 2 to 3 HER2-positive early breast cancer. So specifically, the patients must have either clinical N1 to 3, clinical T3 to 4, or inflammatory breast cancer. And just to note that clinical T1 to 2 N0 patients were excluded. So the patients were randomized to one of 3 treatment arms. Control arm is 4 cycles of AC followed by 4 cycles of THP, which is dual HER2 blockade, plus paclitaxel. Then there are 2 experimental arms incorporating TDXD, an arm that has 4 cycles of TDXD followed by THP for 4, and then there is an arm with 8 cycles of TDXD. Now, this study has good Asian representation. About half were Asian. Over 40% of patients had clinical T3 to 4 disease, and almost 90% of patients had clinical node-positive disease. Primary endpoint was PCR, which is defined as YPT0 and YPN0. So just to note that the TDXD times 8 arm was terminated early for various reasons, including futility and delay to surgery, but this termination occurred after almost 90% of the target patients had already been enrolled. So this study did meet its primary endpoint, and the winning arm is TDXD for 4 cycles followed by THP, which compared with the control arm, there is an increase in PCR rate of 11.2% in favor of the TDXD containing arm in the intent to treat population. And you see similar benefit regardless of hormone receptor status, but the benefit appears to be more marked in the hormone receptor negative population, with a fairly remarkable PCR rate of over 80% in the hormone receptor negative population with 4 cycles of TDXD followed by THP. But if you compare the 8 cycles of TDXD arm versus the control arm, this arm was actually inferior in the intent to treat population. The PCR rate is 13% lower than in the control arm, and you see the similar difference in regardless of hormone receptor status, and again, more marked in the hormone receptor negative population. Now, subgroup analysis showed all subgroups of interest to derive benefit from 4 cycles of TDXD followed by THP compared to AC, and that include patients from Asia, regardless of hormone receptor status and regardless of the nodal status. If you look at the toxicities, just comparing TDXD for 4 cycles followed by THP versus the control of AC followed by THP, there were more adverse events leading to discontinuation with TDXD, but events leading to dose interruption was actually less. Now, if you look at adverse events leading to surgical delay, TDXD for 8 cycles stood out as having the highest incidence, and in fact, this is one of the reasons this arm was terminated early. But more importantly is the toxicities that we are most concerned about, which is interstitial lung disease, which in this case, regardless of whether it's any grade or grade 3 or more, is actually not more than the control arm of AC. So generally, a TDXD for 4 cycles followed by THP for 4 appears to be fairly well tolerated. So if you come back to look more closely at these PCR rates, just want to highlight that it's rather intriguing that 8 cycles of TDXD was actually inferior to the control arm of AC followed by 4 followed by THP times 4. And interestingly, this is actually almost identical to what was reported in another phase 3 randomized trial that has been published some years ago. This is the Christine trial that enrolled over 400 patients with stage 2 to 3 operable HER2-positive breast cancer, randomizing them to neoadjuvant dual HER2 blockade plus combination chemotherapy, docetaxel carbo for 6 cycles, and then pertuzumab plus TDM1 for 6 cycles. And you see those differences are exactly the same, almost identical here, 44% PCR rate there. So this highlights that neoadjuvant ADC alone without other chemotherapy, with or without pertuzumab, is inferior to our current standard of dual HER2 blockade plus combination chemotherapy. So coming back to the current status and the future progress in neoadjuvant systemic therapy in HER2-positive early breast cancer, our current standard remains dual HER2 blockade plus combination chemotherapy for most patients, but the DB05, which is focused on a high-risk clinical stage 2 to 3 population with the majority having clinical node-positive disease, is suggesting that TDXD for 4 cycles followed by dual HER2 blockade plus taxanes could be superior, and this could become a new standard for these high clinical stage patients. Now, there are, of course, other escalated neoadjuvant therapy strategies that are being evaluated. So one strategy is to add checkpoint inhibitor to our standard combination, and this is being evaluated in the phase 3 randomized APT-NEO trial, which enrolled over 660 patients with high-risk early and locally advanced HER2-positive breast cancer, randomizing them 1:2 to arm A, which is the standard arm dual HER2 blockade plus combination chemotherapy, versus arm B, which is further subdivided into B1 and B2 with containing atezolizumab, either combined with anthracyclines containing chemotherapy or non-anthracyclines containing chemotherapy. But rather disappointingly, this study did not show any significant difference in PCR rates with the addition of atezolizumab. So for now, there's no role to add atezolizumab as neoadjuvant therapy. Now moving on to escalated adjuvant therapy in the non-PCR population, our current standard is adjuvant TDM1 based on the Catherine trial, which was a phase 3 randomized trial that enrolled over almost 1,500 patients with clinical stage 1 to 3 HER2-positive breast cancer. So this study is pretty liberal in the patients that they are enrolled. They only excluded the lower stage patients, namely the clinical T1A to B and 0 patients. The patients must have residual disease post-neoadjuvant taxanes plus trastuzumab with or without pertuzumab, and were randomized to adjuvant trastuzumab versus TDM1 for 14 cycles. So a quarter of the patients had upfront inoperable cancer, half of them had pathological node-positive disease, and this being an older trial, only less than 20% of patients had received neoadjuvant dual HER2 blockade. So primary endpoint was invasive disease-free survival, and secondary endpoints included overall survival. And the study met its primary endpoint, the first already reported at the 3-year mark, which at that point, 11.3% benefit, hazard ratio 0.50, and with longer follow-up at 7 years, this widens to 13.7%, with 7-year invasive disease-free survival in the TDM1 at 80%, hazard ratio of 0.54, and this translated into overall survival benefit at the 7-year mark, absolute gain of 4.7%, with hazard ratio of 0.66. But if you look at the adjuvant TDM1 outcomes as a group at the 3-year mark in the intent to treat population, 3-year invasive disease-free survival is pretty good at 88%, but there are some subgroups that have poorer outcomes, in particular those with inoperable upfront disease, those with pathological node-positive disease, especially those with YP N2 to N3 disease. So clearly these patients will require more effective adjuvant therapies. So the Destiny Breast 05 is exactly one such trial to focus on these patients who are higher risk and have non-PCR. So this is a phase 3 randomized trial that enrolled over 1,600 patients with HER2-positive early breast cancer and with residual disease post-neoadjuvant taxanes plus trastuzumab with or without pertuzumab. So just to note that this study focused on high-risk early breast cancer patients, so they are either inoperable upfront at presentation, so either had a clinical T4 or a clinical N2 to 3 cancer, or they were operable at presentation with a CT1 to 3 and 0 to 1 disease, but had pathological node-positive disease post-neoadjuvant therapy. Patients are randomized to adjuvant TDM1 or TDXD for 14 cycles. Again, very good Asian representation, almost half there. More than half the patients had upfront inoperable cancer, and more than 80% of the patients had pathological node-positive disease. And this is a contemporary trial, so almost 80% were treated with neoadjuvant dual HER2 blockade. Primary endpoint was invasive disease-free survival, and this showed significant improvement at the 3-year mark, absolute gain of 8.7%, hazard ratio of 0.47. So subgroup analysis showed most subgroups of interest to derive benefit from adjuvant TDXD, including Asian patients, regardless of the pathological nodal status and regardless of whether they had operable or non-operable disease up front. Again, looking at toxicities, if you compare TDM1 versus TDXD, just looking at adverse events leading to discontinuation, dose interruptions, and dose reductions, they are pretty comparable. But for sure, TDXD for 14 cycles does result in interstitial lung disease, almost 10% here, including 0.2% death, so it's not trivial, highlighting that close monitoring is required, and we do need to carefully weigh the risk-benefit ratio for each patient if you're considering using TDXD. So here, if you look again, comparing the patient characteristics of the DB05 trial for adjuvant TDXD versus the Catherine trial for adjuvant TDM1, it is very clear that the DB05 trial had really enrolled patients who are higher stage, higher risk. More than half the patients were inoperable upfront. 80% of patients had pathological node-positive disease, and also almost the majority received the contemporary, more potent dual HER2 blockade as neoadjuvant therapy. So this highlights to us that if the TDXD does become approved and becomes available, if we are going to use this, it should be reserved for this higher risk population. Again, there are obviously other ongoing trials of escalated adjuvant therapy in the non-PCR population. So there is the COMPASS HER2-RD, which is attempting to look at the addition of tucatinib to standard adjuvant TDM1, and there's the Estefania trial, which is adding atezolizumab to the standard adjuvant TDM1 in non-PCR patients. So given that these emerging data and presuming that TDXD is going to become available to us in the clinic, then which strategy should we be adopting for the high-risk HER2-positive early breast cancer patient? So just note that the DB11, which is neoadjuvant TDX trial, had enrolled high clinical stage patients, with about 90% of the patients having clinical node-positive disease. So for this particular strategy, I think neoadjuvant TDXD we should prioritize for those with clinical N2 to 3, clinical T4, or inflammatory breast cancer. For the patients who have a residual disease post-neoadjuvant HER2 blockade plus combination chemotherapy, DB05 is evaluating adjuvant TDXD, but majority of the patients are high risk with pathological node-positive disease, and I think we should prioritize adjuvant TDXD for this particular population. And I think we should be acknowledge that adjuvant TDM1 is still a very good drug, it's still going to be adequate for most non-PCR patients with pathological node-negative disease. So, but what really should be looking out for are better biomarkers to help us identify the truly poor prognosis HER2-positive early breast cancer patients for more intense escalated adjuvant therapy. And as I mentioned in my earlier talk, ctDNA looks promising. So I showed this earlier on, a study with high-risk early breast cancer receiving neoadjuvant therapy, including HER2-positive patients with serial ctDNA analysis, where ctDNA dynamics is prognostic. Patients with no clearance at all, or those who cleared only after completion of all the neoadjuvant therapy, had the worst outcome. So this could be a useful biomarker. And indeed, there is an ongoing phase 3 randomized trial called the Survive-HERO study that is enrolling HER2-positive or HER2-low early breast cancer, clinical M0, completed primary therapy, but have molecular residual disease, ctDNA positive, and the patients are randomized to TDXD versus standard of care. So this study will tell us whether preemptive treatment with TDXD could potentially prevent recurrences. So to conclude, significant advances have been made in HER2-positive early breast cancer. So our current approach for low-stage, low-risk patients, we go for upfront surgery, higher stage, moderate to high-risk patients, neoadjuvant therapy, gray zone cases we discussed. But what we actually want to look at is better therapy for patients who are resistant to the current best treatment, and DB05 and DB11 have filled an important gap, developing a more effective neoadjuvant therapy as well as a more effective escalated adjuvant therapy for these higher stage, higher risk patients. But there are also other escalated adjuvant therapy strategies that we can anticipate that are still in clinical trials, and we need better biomarkers to select patients for judicious escalation. And then on the other end of the spectrum is what I mentioned earlier on, avoiding overtreatment in lower risk patients. And there is already some proof of concept data from the WSG and the PERGAIN trial that neoadjuvant dual HER2 blockade without chemotherapy could suffice for certain lower risk patients, and this might become the future trend. But again, we do need better biomarkers to select patients for rational de-escalation so that we can fully work towards the true realization of precision medicine. So thank you very much for your attention.
Thank you, Su-Chin. If you want to just join me on stage here, because you'll be going up again later. Okay, so we'll move on to the next talk by Shahina. So she'll be talking about HER2-positive breast cancer in the metastatic setting. Thank you, Shahina.
Thank you. So Su-Chin discussed a lot about how TDXD is now integrated into the therapeutic plan in that first-line early-stage setting, and the metastatic setting has been no different in terms of an explosion of data. But let's just take a step back and see where the standard used to be. The standard was Cleopatra, patients first-line HER2-positive metastatic breast cancer randomized to get trastuzumab plus a taxane-based chemotherapy versus dual blockade plus taxane, and there was a clear-cut overall survival advantage. Some caveats to this study: endocrine therapy was not allowed, and you can see that at least in the clinic, and I'm sure you all have these patients, we have a subgroup of patients in the Cleopatra that have just stayed alive forever and been on maintenance HP, but we also have those patients who've relapsed very early, and you can see that less than 50% will achieve a 5-year overall survival. Destiny Breast 03 set the stage for second-line therapy in those patients with HER2-positive metastatic breast cancer. These patients post-Cleopatra were randomized to get either TDM1 or TDXD, and you can see in terms of a PFS and an OS benefit, clear-cut improvement in terms of favoring the group of patients who are getting TDXD, and this set the standard for second-line therapy. The question then came, can we do better than Cleopatra in the first-line setting amongst patients with metastatic breast cancer HER2 positive? And I think to be able to do that, we need to recognize that HER2 positive disease is not a homogeneous disease. It's really a conglomerate of two different types of diseases. That group of patients who have hormone receptor positive disease and the group that has hormone receptor negative disease. And the questions that we ask ourselves in those patients with hormone receptor negative disease is, can we improve upon Cleopatra? Could we potentially take TDXD from the second line setting into that first line setting? And if we do that, if we give TDXD in that first line setting and it improves prognostic outcome, are we going to treat some of those patients forever? Because as you know, in Cleopatra, you had those patients that went on to stay on maintenance therapy for so long. So the Destiny Breast 09 trial was the first trial that actually looked at this question. Patients HER2 positive metastatic breast cancer, first line, randomized to get either TDXD plus placebo, TDXD plus pertuzumab, or THP. What was read out so far was the arm of TDXD plus pertuzumab versus THP. The primary endpoint was progression-free survival. An important caveat of the study is in these patients, real world, presented in 2025, only 13.5% of patients in the TDXD arm actually received endocrine therapy, and only 38% of patients in the THP arm used endocrine therapy. So something to think about when you're actually thinking about the data for this particular study. In terms of the primary endpoint, in terms of progression-free survival, clear-cut improvement using TDXD plus P versus using a Cleopatra-type protocol, 13.8-month improvement in progression-free survival, associated with a 44% reduction in the risk of progression of disease. And in terms of overall survival, not significant, but a clear-cut trend is seen amongst these patients. When you go into the subgroup analysis, every subgroup is actually benefiting with the use of TDXD, irrespective of the HR status, irrespective of the presence or absence of a PIK3CA mutation, and irrespective of the presence or absence of brain metastases. In terms of overall response, clear-cut improvement of the overall response from 78.6% to 85.1%, and a clear-cut improvement in the median duration of response from 39.2 months to 26.4 months. When we look at progression-free survival too, again, patients who are getting TDXD doing much better than those who got Cleopatra, but again, another caveat, only 10% of patients in the THP arm actually went on to get TDXD in the second-line setting. So you have to put that again into perspective when interpreting the PFS2 results. Now, the second important study that was presented last year at San Antonio was the HER2 CLIMB-05 trial. This took another strategy. It took patients, again, first-line setting, HER2-positive metastatic breast cancer. Here, everyone got a Cleopatra-type protocol as induction therapy for 4 to 8 cycles. They achieved a good response, did not progress, and they were randomized to get either continuation of trastuzumab and pertuzumab versus adding tucatinib to HP. Primary endpoint was progression-free survival. That was the primary endpoint. 53% of patients had hormone receptor positive disease, yet only 45% of these patients actually received endocrine therapy in that maintenance setting. 70% of these patients also had stage 4 de novo disease. In terms of primary endpoint, clear-cut improvement with using tucatinib plus HP as your maintenance regimen. You can see the progression-free survival improve from 16.3 months to 24.9 months with a delta of 8.6 months. So clear-cut, this study was a positive study. But when you stratified it according to hormone receptor positive and hormone receptor negative, you can see the biggest benefit was actually in those patients with hormone receptor negative disease with a delta of 12.3 months. PFS improved from 12.6 to 24.9 months. You also saw an improvement in the hormone receptor positive group, but not as big an improvement, from 18.1 months to 25 months with a delta of 6.9 months. So in that HER2 positive, hormone receptor negative cohort, We know that upfront TDXD or tucatinib plus HPE in that maintenance setting works. It works very well, but it also works in that hormone receptor positive setting. Although both trials, not everyone received endocrine therapy. So that takes us to the hormone receptor positive cohort of patients. Should we be thinking about optimization of endocrine therapy in a HER2 positive, hormone receptor positive metastatic breast cancer patient in that first line setting? Really asking the question, should we consider endocrine therapy? Should we consider CDK4/6 inhibitor? Should we be treating these patients differently compared to hormone receptor negative? And is chemotherapy important? So one of the first studies to actually look at this question in an indirect sort of manner was the PERTAIN trial. This was a phase 2 clinical trial that randomized patients to actually getting trastuzumab, pertuzumab versus trastuzumab alone, both arms with or without chemotherapy. But in those patients, they also randomized them to also get endocrine therapy. And you can see that in terms of induction chemo, the induction chemo was as per physician discretion. So there were patients who got chemo, there were patients who did not get chemo. It had a number of important conclusions. One, pertuzumab was important. The minute you added pertuzumab, the progression-free survival improved. But what you can also see that 16.9 months improvement, 16.9 months PFS with chemo and 26.6 months without chemo, really suggesting that perhaps there is a role for having a chemo-free regimen in these patients with hormone receptor positive metastatic breast cancer, HER2 positive. So in my opinion, endocrine therapy, because everyone received endocrine therapy in this trial, endocrine therapy is important in hormone receptor positive disease. Pertuzumab is important, and perhaps, and it's difficult to select those patients, but perhaps not all patients actually require induction chemotherapy, but it will be difficult to see who does and does not. The second study, which I think is very important, was a DETECT-5 trial. This was a study that actually really asked the question, do you need chemotherapy in patients with hormone receptor positive, HER2 negative metastatic breast cancer, first line to third line, but the majority was in the first line setting. These patients were randomized to chemotherapy plus anti-HER2 therapy versus endocrine therapy plus anti-HER2 therapy. The study was then amended to add ribociclib as a CDK4/6 inhibitor part of this particular study. Two important conclusions from the study. First, you can see the difference between chemo versus no chemotherapy. Although not statistically significant, there appeared to be a trend in terms of improvement of prognostic outcome when you added the chemotherapy to the anti-HER2 therapy, followed by endocrine therapy plus trastuzumab and pertuzumab. So again, telling us there might be a benefit, but that benefit is not as big. Then they looked at that question, CDK4/6 inhibitor versus no CDK4/6 inhibitor, and you can see the biggest benefit is actually coming from those patients who are getting ribociclib plus endocrine therapy, and of course that anti-HER2 therapy with or without chemotherapy, telling us it gives evidence that CDK4/6 inhibitor is important. So then that set the stage for the PATINA trial that was presented at San Antonio a couple of years ago and is now out in the New England Journal of Medicine literally a couple of weeks ago as well. And you can see these were patients hormone receptor positive, HER2 negative, first line patients with HER2 positive metastatic breast cancer. They got 6 to 8 cycles of a Cleopatra type protocol as induction therapy. So everyone actually receives Cleopatra. And then if they had stable disease or a good response, they were randomized in the maintenance phase to get either palbociclib plus anti-HER2 therapy and of course endocrine therapy versus anti-HER2 therapy plus endocrine therapy. Primary endpoint was progression-free survival. And you can see that 90% of these patients actually received an aromatase inhibitor. It met its primary endpoint, very nice separation of the Kaplan-Meier curves, very early separation of the Kaplan-Meier curves, with the PFS actually improving from 29.1 months to 44.3 months, which translates into a 15-month improvement in that progression-free survival, translating into a 26% improvement in the risk of progression of disease. So this tells me that in the hormone receptor positive, HER2 negative MBC setting, endocrine therapy plus anti-HER2 therapy plus CDK4/6 inhibitor improves progression-free survival as a maintenance therapy post-induction with Cleopatra. So the questions I asked myself, post the tsunami of data that came out in the last couple of years is, first, is DB09 for everyone? In my opinion, probably not. We will need to pick and select our patients very, very carefully. Is pertuzumab needed in combination with TDXD? Because remember, in DB09, patients were randomized to TDXD, TDXD plus pertuzumab, or Cleopatra, and the TDXD alone arm was not actually read out yet. But we do have results from the Destiny Breast 07, which was a phase 1, phase 2 trial. Again, a very interesting study, first-line setting, randomizing patients to TDXD monotherapy, TDXD plus pertuzumab, or TDXD plus durvalumab. They've read out TDXD monotherapy versus TDXD plus pertuzumab, and at least for me, in terms of the PFS and OS, visually, I'm not seeing a difference between the two arms of the study. Overall response rate for TDXD was 78%, and TDXD plus P was 84%. So is pertuzumab needed in combination for TDXD? Maybe not, but we will have to wait for further follow-up of the Destiny B09 trial. Now, the next question is, will sequencing Cleopatra followed by DB09 give you the same result? I think it's a difficult question to answer because only 10% of patients in the THP arm actually went on to get TDXD. But if you really think about it, we did have DB03 that set the standard for TDXD in that second-line setting. So perhaps it may not actually give you the same answer. In the triple-positive cohort, is DB09 the correct strategy? Well, I want to go back to Cleopatra and compare it to the Patina trial. In the Cleopatra trial, when you see that drop in the Kaplan-Meier curves, you do have a loss of about 20 to 25% of patients who progress very, very early. And when you see Patina, you see a very nice separation of the Kaplan-Meier curves right at the very beginning. This is actually not reflective of what is actually happening because these patients got induction. If they did not progress, they went on to get Patina. So you are actually losing 20 to 25% of your patients before they actually get on to Patina. So perhaps telling us Cleopatra may not be the optimal induction regimen before going on to a Patina type of maintenance. So I put this together in terms of the PFS for looking at those patients with hormone receptor positive, HER2 positive metastatic breast cancer, Cleopatra. You can see the PFS is 27.2 months. DB09 is 38 months, but remember, only 13% of these patients received endocrine therapy. Patina was 44.3 months. Everyone gets endocrine therapy plus a CDK4/6 inhibitor, and HER2 Climb 05, only 25 months. But here, 45% of patients received endocrine therapy, telling me it's not as optimal a maintenance strategy. So how will we use these three protocols in that hormone receptor positive setting? You could either do Cleopatra followed by Patina type maintenance strategy, but remember, you could lose 20 to 25% of your patients before they get onto Patina. You could do TDXD followed by a Patina type strategy, or you could do TDXD followed by TDXD plus endocrine therapy. Like I said, in the Cleopatra upfront strategy, risk of losing patients upfront. The TDXD followed by Patina may be a good induction strategy. And if you did TDXD throughout, there is that risk of long-term toxicity of going on with a TDXD type protocol forever. So in the triple negative positive cohort, is DB09 the optimal strategy? Well, we know that endocrine therapy is important. We know that CDK4/6 inhibitor therapy is important. Whether or not optimization of endocrine therapy in DB09 would have helped, we will never know the answer to this question. A select group of patients, as they pertain, may not actually require any type of chemotherapy, and perhaps a strategy of induction followed by endocrine therapy plus CDK4/6 plus anti-HER2 therapy may be where we're going with this. In the ER-negative cohort, will we need to consider a maintenance type strategy? The simple answer is yes, and I'm going to go through these 4 strategies of doing TDXD followed by TDXD is one strategy. I think toxicity will be a concern. Or doing TDXD followed by TP, will it work for everyone is the question that we have here. Or perhaps doing TDXD followed by tucatinib plus trastuzumab pertuzumab. Again, the toxicity associated with tucatinib is not something that we should think lightly of. Or you just do your standard Cleopatra followed by tucatinib plus trastuzumab pertuzumab. I think here toxicity will be a concern, and I'm still skeptical about whether we're achieving the same efficacy as if we had done TDXD up front. So the next question is, what will we use if there is brain metastases at baseline? Simple answer, you need an MDT discussion for these patients. And remember, in the HER2 CLIMB trial, we did see patients with brain metastases where tucatinib and HP was superior to using just an HP-type protocol. And of course, we have the results of the Destiny Breast 12 trial that took patients who had brain metastases, HER2 positive, and gave them TDXD. Some of these patients had active brain metastases, untreated brain metastases, as well as treated metastases. None of these patients had received tucatinib. And I think these are very, very good data telling us that in terms of progression-free survival, as well as in terms of PFS for the whole population and in the CNS, this is very good results telling us there's good activity for TDXD in these patients with brain metastases. So in my final slide, this is my personal opinion. In patients with only brain metastases upfront, and you will have those patients who recur with only brain metastases, I think this is the sort of group of patients you need a proper MDT discussion where you're integrating local therapy, TDXD, TP plus endocrine therapy CDK4/6 inhibitor, because we know some of these CDK4/6 inhibitors actually go into the brain. What if you have a patient who recurs and has brain metastases and distant mets, or stage 4 de novo brain metastases and distant mets? For me, this would be the type of patient I will do TDXD plus P up front, because we know it has good brain activity. What we will do in the maintenance setting, I think, is an unanswered question, and we probably have to individualize. In your patients who have stage 4 de novo disease and has hormone receptor positive disease, you have the option of doing induction THP or TDXP as your induction, and I really would strongly recommend doing a patina type maintenance in these patients because it works, and it works very well, and I've shown you those PFSs. And in that select group of patients, perhaps that 80-year-old who will get a lot of side effects, perhaps we can do a chemo-free regimen of doing just patina, where you give CDK4/6 inhibitor, anti-HER2 therapy, and an AI. And then post-progression, you could then re-challenge with TDXD. In that hormone receptor negative cohort, of course, everyone gets TDXD plus P, and you may consider maintenance either with HP or tucatinib, HER2 CLIMB type protocol, but I'm more inclined to do TP because I still think we need a lot more follow-up for tucatinib plus TP, and it has a lot of toxicity. And then when they progress, you can either re-challenge with TDXD or do a Cleopatra type protocol. In your recurrent setting, if you have a disease-free survival of less than 6 months, these patients up front, they need TDXD plus P. And then, of course, if they've got hormone receptor positive disease, do not forget to optimize endocrine therapy. But if they've got a disease-free survival of more than 6 months and hormone receptor positive disease, again, use an induction TDXD plus P or even a Cleopatra type protocol. Although for me, I think in a recurrent setting, I would probably do TDXD plus P, of course, followed by patina, and then upon progression, re-challenge with TDXD. In the hormone receptor negative setting, again, TDXD plus P, maintenance HP, and then upon progression, you could potentially re-challenge. So thank you very much.
So we'll move on to the case discussion. If we can invite Suchin to give the cases, and Prof. Lu, thank you for coming on board to join us. Yeah.
All right, okay, so I'll move on to the case discussions, and I prepared 2 cases, and then we can see what our experts think, and I'll also have a chance to poll the audience. So the first case is a 56-year-old female who presented with a clinical T2, 3.7 centimeter, N0M0, left breast cancer, is ER and PR strongly positive, HER2 was 3+, she was treated with neoadjuvant dual HER2 blockade, plus combination DDAC times 4, followed by dual HER2 blockade, plus weekly paclitaxel, but she received only 11 weeks of paclitaxel. The last dose was omitted for peripheral neuropathy. Went on to surgery, and there was residual tumor, 1.1 centimeter, N0. It's still ER/PR positive, but HER2 is negative. So now I maybe want to start with Professor Lu. How often do you routinely get that checked in the post neoadjuvant sample number one, and how often do you see a change like this?
Several years ago, we didn't do that. And once we have this kind of case, now we routinely recheck that after neoadjuvant. The reason is that maybe more than a couple months during our multidiscipline discussion, we have this kind of case frequently. And according to our pathologists, we can divide them into two parts, two different parts. One is hetero, one is mosaic. Mosaic means that the tumor separate quite clear. One is HER2 3+, and one is HER2 low or 0 in the biopsy part. If so, then we consider that it's heterogeneity in the very beginning. And so for this patient, just very reasonable to understand for the HER2 part, they have almost PCR. For the luminal part, of course, they will not respond to the treatment very well.
Right. Okay. So maybe Shahina. Okay, so I think we all see HER2 changes, right? But this is kind of a drastic change. So do you often see such a drastic change from one extreme to the other?
I don't think it's very common, but I think at least in my data set, in my clinic, we've been testing it routinely for the last couple of years, similar to what you guys are doing at your end. And we've seen about a 20 to 25% probability of it changing from a positive all the way to a negative.
Right. Maybe I'll just ask the audience, just show of hands, right? Because I think this is always a dilemma. Then it's like, should we ask for trouble to check it again? So how many people routinely check it, the post-neoadjuvant sample? Oh, quite a lot. And how many is like, I'd rather not know. We don't check, and I'd rather not know. Okay, all right. Okay, all right. So Kylie, you'd rather not know, but heck, someone checked it. So what adjuvant therapy will you recommend?
I mean, she would qualify for TDM1 anyway, with, even if she's HER2 negative. So that's why I don't routinely check for everyone, because here people have to pay for the test.
So, okay. All right, so maybe I'll ask these, and so you'll give TDM1, right? Yeah. So maybe I'll ask the audience who would give TDM1 for this patient? Who would give just trastuzumab, not TDM1? Who would give some other chemotherapy, capecitabine? Okay, everybody's giving TDM1. Well, guess what? This patient...
Could I play devil's advocate here? So, you know, we all base our treatment of TDM1. This is exactly what I would do. I'd give this woman TDM1. But if you look at the data from Catherine that actually told us we could give TDM1 in those patients who would turn HER2 negative, it was only 60 patients. We're basing our whole decision landscape on 60 patients. And I wonder, this patient is ER/PR positive, HER2 negative. Would it be better to actually start off on a CDK4/6 inhibitor plus endocrine therapy in this patient who would probably benefit more from it? And I think that's a question that we will start to ask ourselves in the clinic.
Yeah, so if it's a true distinct clone, then I guess you would really have to have a discussion. So Prof. Lu,
I will suggest to review the slide with pathologists for the biopsy part. If they are mosaic part-like, it means that part of them are truly luminal, and clearly this is a PCR for HER2 part, then there's no need to go to TDM1. But if it is hetero part, then this fulfills the criteria of Catherine, even though, as you mentioned, patient number is low, is low, but still was controversial.
Okay, all right. Anyway, this patient did not get TDM1. She would receive adjuvant single-agent trastuzumab, and then had adjuvant letrozole, and then she was on it for about 4.5 years. At age 60, she became age 61, and then did a pre-minor procedure, chest X-ray for something else, and there were incidental bilateral lung nodules shown here. Went on to do a CT thorax, abdomen, and pelvis that showed bilateral lung nodules, mediastinal lymph nodes, had a biopsy done of those mediastinal lymph nodes, and is confirmed to be metastatic breast carcinoma, ER, PR still strongly positive, HER2 2+, FISH positive. So I want to poll the audience again, just show of hands. What first-line therapy will you recommend for this patient? Who's going for the standard, pertuzumab, trastuzumab plus chemotherapy, the old standard? Some hands. Who's going for the new standard, TDXD plus or minus pertuzumab? Some hands, seems more than the first. Okay, so I think we can skip that. I would like to ask maybe Professor Lu, what first-line therapy would you recommend this patient?
I think this patient has relatively long disease-free survival. So both treatment are is okay. But given the current data showing that TDXD are associated with a relatively higher chance of clinical CR rate, and we just have a myth that clinical CR may equivalent to have a long tail, that they might have a relatively long disease control. So to giving that, well, I will suggest TDXD, especially since this patient already exposed to Cleopatra-like regimen 5 years ago.
Okay, but it's more than 5 years ago.
More than, yeah.
Yeah, okay. So, all right, but Shahina, does the prior history of this HER2 status, wild changes in the HER2 status from 3+ to 0 to 2+ bother you?
No, it actually doesn't bother me. This patient has a heterogeneous disease. We see it all the time. What bothers me is the FISH result, the ratio being just 2.2.
Okay.
And I see this a lot where I feel like labs are making a mistake where they don't know if it, that 2.2, that like low amplification is probably truly hormone receptor positive, HER2 negative, but they got it wrong. So this makes me nervous, and I would probably not give her chemotherapy as a Cleopatra type protocol. I'd probably do TDXD, couple of sessions, get that induction in, and try and get the CDK4/6 inhibitor plus endocrine therapy as fast as I can, because I think that is the more important thing for this patient. At least that's the way I feel.
Okay. Kylie, so if you recommend first-line dual HER2 blockade plus chemotherapy, which chemo will you give? Because she couldn't finish all the paclitaxel.
Okay, so I presume that the taxane is out of the question here. So there are some first-line trials to show that non-taxane-based chemotherapies can work, like the Japanese trial with eribulin. Vinorelbin is also an option for the patient as well.
All right, you would avoid taxanes altogether. Would you consider 3-weekly docetaxel? Yeah, go ahead.
Oh, me?
Yeah,
Okay.
maybe Professor Lu can.
I mean, we have to talk about it. If she still has fairly significant neuropathy,
So
then probably
it's not significant, but it was enough for her to not complete the 12 weeks, but now she just has the usual little bit of lingering. But then she was like, that was a bad experience.
I'll hand over to...
Okay, Professor Lu, would you give, is taxanes out of the way, would you consider docetaxel?
Well, I will consider docetaxel since she already exposed to paclitaxel before.
Okay, all right. And, okay, so I think this is a question that Shahina, you raised it, and I think it's a very valid point, right? So if you recommend first-line TDXD, how important is the pertuzumab? Say it's a real patient, and can afford some things, but it's not so, I mean, it's not like, it's like totally not a consideration because everything adds on, right? Yeah, so if they can afford TDXD, but maybe if you add on the pertuzumab, it's going to be far more expensive.
I'd get AstraZeneca to give the pertuzumab for free to the patient, quite honestly.
Okay.
But if we can't get the pertuzumab, I think I've shown the data. I think for me, visually, it looked the same. I would try and stick to the trial because we have to stick to the phase 3 trial.
Right.
But if I couldn't, I would still give TDXD.
Okay, so I want to ask the audience, so if you are going to give first-line TDXD, how many of you are going to give TDXD plus pertuzumab, exactly like the trial, exactly on the label? And how many of you are going to just give the TDXD and forget about the pertuzumab? Oh, quite a lot of people. Okay, all right.
Maybe I should.
I'm going to ask the audience first. Okay, so, we're going to give first-line TDXD with a plus or minus pertuzumab. So how many people are going to go exactly like the trial and treat until progression? Follow the trial exactly, treat until progression. How many are going to, I'm just going to give 8, 10, 12 cycles and then switch to maintenance? Finite duration and switch to maintenance. Okay, all right. Okay, Kylie, what would you do?
Switch to maintenance.
Switch to maintenance. How many cycles?
So I'll treat for 4 to 6 cycles.
4 to 6, okay, all right. Professor Lu, you agree 4 to 6 is enough to get
No,
your clinical
I
complete
consider
response?
to give longer cycles, still have the myth that we need to control the tumor to a relatively minimum size, then have a maintenance therapy. And I still believe that in that scenario, they will have a much longer long tail or disease control.
Okay. All right, so this patient received first-line dual HER2 blockade plus docetaxel, 6 cycles with good partial response. Docetaxel was stopped and was maintained on pertuzumab plus trastuzumab. So, Shahina, you will add endocrine therapy, right? But
Yes.
which one would you add? Because she progressed on letrozole. She relapsed on adjuvant letrozole.
So she progressed on adjuvant letrozole, but she never got a CDK4/6 inhibitor.
No.
And we have plenty of data to show us that adding the CDK4/6 can reverse resistance. So I wouldn't give letrozole. I would try aromasin, like a non-cross-resistant one,
Okay,
AI.
another
and
AI,
I would
okay.
give a CDK4/6 inhibitor like palbociclib. I think it's reasonable to use any CDK4/6
Okay.
inhibitor.
Okay.
And of course, tag on the TP portion
Right.
of it.
Kylie, what endocrine therapy would you give?
Okay, so we can possibly use fulvestrant, but I think it would make the treatment quite complicated. They have to come back 3 weeks,
okay.
4 weeks, 3 weeks, 4 weeks. So like what Shahina said, it's
Okay.
very, very reasonable. And palbociclib, yeah.
So you will use another AI. And Professor Lu too, or you have a different opinion?
I will add on Pablo, but it's very difficult to choose the partner endocrine therapy. AI followed by AI, I'm not really convinced by the study, but tamoxifen has been shown to be inferior to AI in HER2 setting. So I have no answer for that.
Okay, all right, but you will all add palbociclib if you're going to get onto that, right? Okay, so I'll move on to case number 2. This is a 50-year-old female who presented with a self-palpated right breast lump. Clinically, it's a 1.5 centimeter right breast lump, no palpable axillary lymph nodes. Biopsy showed grade 2 invasive carcinoma. This is ER/PR negative, HER2 3+, CT scan, no distant mets, no enlarged axillary lymph nodes. I want to poll the audience first. Who will recommend upfront surgery for this patient? Upfront surgery. Okay, quite a lot. And who will go for neoadjuvant systemic therapy?
No, sorry, neoadjuvant.
Okay, neoadjuvant. Okay, all right. Okay, fine. All right, so we're going to skip that. The patient went for upfront surgery, and then this was the final histology, so we regret that we did the upfront
This
surgery.
is why she needed neoadjuvant.
Yeah, this is why. Okay, all right. So then you got the foresight to give a neoadjuvant, but anyway, it was 1.9 centimeter, went for upfront surgery, and then had 2 out of 2 sentinel lymph nodes, another 10 axillary lymph nodes removed, and 4 more were involved, so total final stage is there, 6 out of 12 lymph nodes. So she was referred to the medical oncologist to discuss adjuvant therapy, but before she could even get there, she was admitted for severe headache. The A&E did a CT scan of the brain, and there's the CT brain and the MRI that showed a 5 centimeter right parietal lobe lesion with perilesional edema and mass effects. So, Professor Lu, do you routinely scan the brain as part of staging for HER2-positive early breast cancer?
Yeah, according to current rule, we didn't do that. But I think that the society need to rediscuss this point, and then it's time to make a change.
Yeah.
Time to make a change. Okay, all right, cautionary tale. And Shahina, how will you manage this patient now?
Oh, I would give her upfront TDXD. I would bring down the edema with dexamethasone, get her to be less symptomatic, and then I would start her on TDXD. But before that, I would do a full staging workup because she needs at least a PET or a CT to see this disease anywhere else.
Okay.
If there isn't, if there isn't, that is different. But if there is, then TDXD would be my choice. If there's disease somewhere else.
All right, Kylie, will you do anything different?
So I will focus on local therapy to the brain.
Right.
Surgery plus or minus radiotherapy.
Okay.
That's
first.
even if the patient had distant metastatic disease?
No
Assuming-
distant,
That's what I
let's say no
said.
distant
It
metastasis.
depends on
Assuming.
the
So
staging
let's say
workup.
no distant metastases. We did a PET scan. There was nothing else. This is the only lesion.
So then that would be different,
Then you
yes,
do
for
local
sure. Then
therapy.
you have to integrate local therapy for sure.
Okay, all right. So this patient went for resection of that right parietal lobe lesion, and it was confirmed to be metastatic breast cancer, but it's a little bit of ER there, 10%, PR 5%, previously was ER/PR negative, still HER2 3+, and she recovered perfectly well, no measurable disease. So, Professor Lu, will you recommend systemic therapy now, or you'll watch and wait? No asymptomatic, no measurable disease.
In before, I will watch and wait, but now I still believe that after surgery, it's very difficult to have a clear margin by the surgery. If they create a big margin, then they will have just some damage to the brain. But if they just too close, too close, then there has some residual disease.
Right.
And since the TDSE have a very good response to
Okay.
penetrate, so I will recommend that at least couple cycles
Right.
of TDSE.
First line TDXD. Shahina?
So this patient has, you said, no evidence of disease anywhere.
Nothing that you can measure radiologically.
So then for me, I would give her your standard protocol of Taxol, carboplatin, pertuzumab, trastuzumab, with the intent to try and cure this patient. We can't give TDXD because it's not there's no neoadjuvant type setting over here. We can't, it's not a residual type setting.
Right.
We've removed everything. She's NED right now. So I would prefer to give her chemotherapy with trastuzumab, pertuzumab, finish that off. And since the ER is 10%, I'd definitely give endocrine therapy and a CDK4/6 inhibitor with THP, just to add on that bit, since she had brain mets and it was such large volume disease.
Kylie?
I would watch her.
You will watch.
You would not give her any systemic therapy at all?
I mean, she has metastatic disease that is resected. And
No, but she didn't get chemotherapy for the breast and the 10
Yeah,
lymph
I know.
nodes that are positive.
But she's NED. And she's metastatic. So at least for me, I think she's incurable. And it's a matter of time where her disease will come back again. I mean, yeah, that's my point of view. Yeah.
Maybe just quick poll for the audience. Who will watch and wait? And who would give something?
I would give something.
Okay. Most
Everyone
people
put their
would give
hands up.
something. I think nothing wrong with watch and wait because it's metastatic, right? Okay, so we went through that. Okay, so now I would like to ask, so maybe Shahina, because you covered that nicely. So this patient, you said that, okay, so let's say we're not trying to cure her, right? It's truly metastatic. First line, de novo metastatic, and the options are all there, but the ER and PR is kind of low. So, but she has CNS disease. Between maintenance tucatinib versus maintenance palbociclib, how are you choosing?
For me, I would still do a CDK4/6 inhibitor because you've resected everything and there's no evidence there. Should the disease come back in the brain, that's a different question.
Okay.
But for me, as of now, since you've removed everything, you've given her the radiation therapy, we've given her chemotherapy, I would maintain her on a CDK4/6 endocrine therapy and trastuzumab, pertuzumab for now.
All right, last comment from Professor Lu. Do you agree or disagree?
I prefer tucatinib since that she has a brain mass in the very beginning.
Okay, tucatinib. Okay, all right. So in the interest of time, I will end this session. And thank you very much for the fabulous faculty and for the audience for also participating. Thank you.